everybody, welcome back. This is Kathy from Synapse Care Solutions. We are bringing you another live stream, and it is now week 2 in our Silent Night in the NICU series. We're focusing on sleep, attachment, and giving in the NICU. I really hope that you enjoy this presentation. It's a replay from our 2021 conference where we talked about maternal infant attachment. We know that the experience of the NICU is a disruptor to attachment, normal parent-infant attachment. But there are things we can do, and Dr. Sanders gives us such a great overview of the science, the history of this topic, which goes back to the 50s and 60s, and then gives us some practical implications, especially coming out of COVID, which the presentation was in June of 2021, and we were all still trying to scramble to get back to our old practices of family-centered care post-pandemic, and maybe you're struggling with this in your unit still. I hope this presentation will inspire you and remind you how important parent-infant attachment is and how we need to be aware of how that impacts lifelong attachment and relationships. So I, again, just want to say a big thank you to Dr. Sanders for being part of our faculty. Definitely check out her book. It is now available on Amazon. I know you're going to love that as well. And I guess any other housekeeping is click the link in the show notes below or scan the QR code here on this screen if you'd like to get access to any of our past replays in this series, or if you'd like to get some of the resources mentioned in this video, or if you haven't already, hit that like and subscribe button. It helps us out a lot. It tells YouTube you like videos like this, helps us to bring you more free content. So if you haven't already, head over to YouTube, hit that subscribe button. It really helps us out a lot. So without further ado, please enjoy this presentation from Dr. Marilyn Sanders.
All right, welcome back, everybody. I am happy to introduce our next speaker, who is going to talk about secure attachment and promoting safety and connectedness in the mother-infant dyad. I have Dr. Marilyn Sanders. She's a board-certified pediatrician and neonatologist who cares for critically ill babies, infants, and their families at Connecticut Children's Medical Center in Hartford, Connecticut. Dr. Sanders did her pediatric residency at University of Connecticut School of Medicine and her fellowship in neonatal perinatal medicine at Johns Hopkins School of Medicine. She's a professor of pediatrics at the University of Connecticut, and she also provides neurodevelopmental follow-up for babies and infants up to 3 years old. Scholarly interests include providing trauma-informed care to hospitalized newborns, infants, young children, and their families. Her focus is on the impact of the autonomic nervous system's sense of safety, danger, or life threat on our emotions and behavior. She is an active presenter throughout the US and Europe and has authored many papers and book chapters on trauma-informed care for infants, children, and families in the hospital setting. Dr. Sanders and her co-author, Dr. George Thompson, are currently working on a book contract on their book, The Polyvagal Theory in the Developing Child, Strengthening Children, Families, and Communities, is due to come out next month and discusses implications of the polyvagal theory for the well-being and development of infants, children, and adolescents. Dr. Sanders is also on the advisory board of the Polyvagal Institute. And we welcome Dr. Sanders.
Good morning, everyone. Thank you to Kathy and the organizers of the One Conference. It's indeed a privilege to be speaking to you today about something about which I am very passionate, which is promoting safety and connectedness between mothers and their babies. I have no disclosures. So I do have some formal objectives today. We're going to talk about the biological expectancies of the human newborn. We're going to talk about neuroceptive states of mammals. That's a term that you'll be more familiar with in a few minutes. And we're going to talk about long-term outcomes of secure attachments. But if I were to really tell you my crystal clear objective, it would be the following. What I hope you walk away understanding is that babies, children, and adolescents are both supported and scaffolded by adult caregivers who recognize both their own and their children's unconscious nervous system responses, will be resilient and protected against toxic stresses.
Dr. Sanders, sorry to interrupt. Can you share your screen? We can't see slides if you have them.
Pardon me. We good?
Yes, they're perfect.
Okay, very good. So sorry. So I'm going to introduce myself for just a moment. I've been a pediatrician and neonatologist for the past 35 years. And in my clinical work, I do acute and chronic care of critically ill babies and their families in a level 4 NICU. I do developmental follow-up for NICU graduates, and I provide perinatal neonatal palliative care. There are several scholars who have influenced me over the course of my career, and I just want to introduce them to you very briefly. First is John Bowlby, known as the father of attachment, a psychiatrist psychoanalyst from the United Kingdom. Second is Heidelise Als, a psychologist from Germany who taught me a lot about the relationship between the parent, caregiver, and babies, and taught me that babies communicate through their behavior. And finally, Stephen Porges, also a neuroscientist and the developer of the polyvagal theory that you'll hear about in just the next couple of moments. So my life's work is exemplified in this beautiful photo of a little baby who was cared for in our unit more than 10 years ago. My life's work is devoted to enhancing the health and well-being of babies, children, and adolescents and their families by recognizing opportunities to build resilience and resistance to stress by optimizing their early relationship. I don't need to tell anybody on this conference that we live in unsettled times. No matter how challenging things might have been for our babies and their families in prior times, obviously the advent of the COVID pandemic took things to an even higher level. So just imagine everything I'm going to talk about in the next 40 minutes or so, and think about how much worse it has been in COVID, when families themselves are lacking the scaffolding and support that they typically would have available to them. So we begin by talking about the stress hierarchy. Life is stress. It's as simple as that. The only state in which there's no stress is death. But stress is variable in terms of its impact, and not all stress is bad. So if we think about the stress hierarchy, we start at the bottom with positive stresses, like this little guy on the right, beginning to take his first steps. Positive stresses are associated with brief increases in heart rate and mild elevations in stress hormones. But the important thing in positive stress, which is growth, is that there is an adult caregiver available to support the child. Next up the hierarchy, of course, is what we would call tolerable stress, which are serious and temporary stress responses, but those that are buffered by supportive relationships. Needless to say, being hospitalized in a newborn intensive care unit is at the very least a tolerable stress. But at the top, or depending upon how you look at it, bottom of that hierarchy are toxic stresses, which are prolonged activations of stress response systems in the absence of protective relationships. And all too frequently, families fear, and we fear, for good reason, that hospitalization in a newborn intensive care unit is potentially a toxic stress. So we're going to begin by talking about our hierarchical, evolutionarily determined biologic needs. And we have to think first about what newborns and young infants expect from their caregivers. Newborns expect that their parents be in emotional and physical proximity to them. They expect sensitivity and attunement from their caregivers. They expect contingent responsiveness. So the baby or the infant makes a move, the parent responds, and the baby responds again, and so forth. And over time, they expect, from a biological evolutionary standpoint, social connectedness. But when I talk about social connectedness in this talk, I'm referring to it in a very, very specific way, as the ability to mutually, synchronously, meaning together, and reciprocally in a back and forth fashion, regulate both physiological and behavioral state. And whether there's this father showing his delight with his infant, the older and younger individuals in a handshake, or this little boy with his dog, there is something very special going on between these two mammals. We also know that social connectedness is a biological imperative for mammals. Think about that for just a moment. Mammals simply cannot survive infancy without being connected to an adult caregiver. So whether you're a chimpanzee, a dog, a little lion cub, or a human infant, if you do not have the support and protection of an adult caregiver, not only do you not thrive, you die. So as we think about this, what I'd like to direct your attention to at this point is an evolutionary perspective of how this social connectedness develops. And to think about that, we have to go back to the first vertebrates who came on land, who were reptiles, as you see on the top left here. Reptiles had only one response of which they were capable if they sensed danger in the midst. And that was basically to try and blend in, camouflage, be very small, and hope that the predator would simply go away. And that's something that derives from a very primitive part of the autonomic or unconscious nervous system called the parasympathetic dorsal vagal complex. Next up the evolutionary chain is the response of higher vertebrates, such as fish, where the sympathetic nervous system came online. And fish had the capacity to actually stay and fight or flee if they sensed danger. But it is only in mammals that the capacity for social engagement is present. Mammals socially engage with each other and try to remain safe by feeling the comfort and support of another mammal. And this derives from a higher portion of the unconscious nervous system called the parasympathetic ventral vagal complex. Now, many of you may think about the parasympathetic nervous system and the sympathetic nervous system as working antagonistically to each other, that you're either sympathetically mobilized or parasympathetically engaged. But indeed, we need both of these. So it's neither good nor bad to be in a parasympathetic state or a sympathetic state. The question is, what is going on at the moment? What does your unconscious nervous system sense? And what do you need to do to either regain safety or maintain safety? Because for mammals, the biggest fear is essentially to be alone. So a very deep portion of our central nervous system, called the limbic system, is constantly searching the environment for danger. And danger for an infant is being alone. The sensory input that we have from our unconscious nervous system has two components to it. It has an external component to it, which is basically what we are sensing in our environment, which includes the relationships that are in our environment. And those together give us a sensory experience that is then sensed internally and is manifested in the visceral or organ-based responses that we have. And there's a lot of words for this. People will use things like, I feel it in my bones, for example, or he's scared to death, for example. And this external environment and internal environment together create what Dr. Stephen Porges called a neuroception. And a neuroception is an awareness from our unconscious nervous system as to whether we are safe, in danger, or in a life-threatening environment. And what I want you to notice is how quickly we can go back and forth between safety, danger, or life threat based upon the cues that we sense, again, unconsciously, deep-seated in the limbic system. And I would propose to you that infants and children who feel safe and secure are available to socially engage. And ongoing social engagement builds social connectedness, which, as you remember, is both synchronous and reciprocal. And social connectedness over time leads to secure attachments, which we know are associated with health and well-being. And I'd like to think that what we get is an iterative circuit, which I call the safety circuit. When we feel safe, we're available to socially connect. When we socially connect, we feel safer. And over time, we can develop secure attachments either to adult caregivers, to friends, to spouses, to teachers, to nurses, to doctors. You can have many secure attachments in your world, and you can never have too many. So that what we hope, under the best of circumstances, is that babies and infants are well scaffolded so that over time that feeling of safety and connectedness leads to a world of secure attachment. So once again, thinking about what our newborns and young infants need from us, they need for us to be in physical and emotional proximity. They need for us to be sensitive and attuned. They need for us to be contingently responsive to them, and they need to be able to socially connect. And I would ask you for a moment to think about a baby and a family in a newborn intensive care unit and how these biological expectations of the infant and the family are potentially interrupted. We know that when babies are inside the womb, it is the mother's local environment that regulates the baby. And once the baby is born, of course, that regulation, which now takes on the form of actual social engagement, is transferred to the parental unit. So the parent essentially becomes, early in infancy, the second womb for the infant. And when we think about how this potentially plays out, these neuroceptive states that we've talked about, if we are feeling safe, we are in the social engagement system. And when you look at this picture, you can clearly see by this mother's facial expression, the vocalizations that you can imagine she's exchanging with her young child, the listening behaviors that she has. These foster calm both in her and in her young child by both inhibiting sympathetic influences, that would be, for example, your epinephrine, and blunting the hypothalamic pituitary adrenal axis, which is the source of cortisol. And over time, as they continue to engage, as they continue to connect, those connections lead to love and secure attachments. If, however, there is an interruption in those relationships, interruptions, for example, as we see in newborn intensive care, then babies who don't have their secure parental caregivers involved engage in fight or flight, and they are sympathetically activated. And those of you who, of course, spend a lot of time at the bedside of babies see this all the time. You see the tachycardia, you see the tachypnea, you see the elevated blood pressures, you may see dilated pupils. We know that in older children and adults, you get inhibition of excretory functions because you can't be peeing or stooling if you need to get away. You mobilize muscles. And babies show these fight or flight responses by crying, by protest, or by gaze aversion. But at the bottom of this hierarchy, at the very bottom, in the situation of life threat or immobilization, we see parent-infant dyads, such as you see with this mother, for example. People are vegetative, they are passive, they are reflexive, they shut down. It is, in essence, the human analogy of the early vertebrate behavior, blending into the environment. In infants, we may see things like loss of tone, despair, or apathy. In older children and adults, we may see fainting episodes, feigning death, or even clinical dissociation. And when you look at this face of this mother, ask yourself, how many times have you seen that face in your newborn intensive care units? Once again, the limbic system is on patrol, scanning for danger. That baby that we just saw knew that his mother was absent. You can see it in his face. She is not present for him. Now, some people might think that the best relationships are those in which mothers or fathers and infants are constantly in synchrony with their babies. But the fact of the matter is that constant synchrony itself is stressful. because the baby can't get away, can't get a pause if he or she needs to catch their breath. And we know that even in the best of relationships, disruptions occur. Disruption is stressful, but chronic disruption is potentially traumatic. So it's not about the disruption, it's about the repair from the disruption. And I would like to think that in our newborn intensive care units, we are focused on how can we repair disruption. So in the last talk you heard, for example, you heard discussion of kangaroo care in newborn intensive care units, even for critically ill babies. That is a repair of a biological disruption. Lyons Ruth is a psychologist who has written extensively on trauma-informed care and the impact of trauma in our youngest population. And she says the following: the relevant traumas of infancy most often result from the hidden traumas of caregiver unavailability and interactive dysregulation. These hidden traumas are woven into the fabric of interaction between caregiver and infant and do not necessarily stand out as salient events to the observer. As John Bowlby said, life is best organized as a series of daring adventures from a secure base. Let's talk next about Bowlby's theories of attachment. So John Bowlby was a psychiatrist and psychoanalyst in the United Kingdom in the 1930s and 1940s. And he started his career in a child guidance clinic where he identified, and this was what they were called, juvenile thieves, in other words, young adult males who were in the child guidance clinic because of behaviors in which they had engaged, which were against the law. Basically, for these kids, it was stealing. And what he noted was that a large majority of them, indeed 86% of them, had what he called an affectionless psychopathy. But the even more interesting thing from our standpoint is that he noted as he came to know these young men and know their histories, that the vast majority of them had prolonged separations greater than 6 months of age from their mothers at less than 5 years of age. So at the very time that they should have been engaging on an ongoing basis with their mothers, developing those secure attachments, there were disruptions that were significant. And from there, he developed his theory of attachment behavior. And what he came to understand as he studied not only these young men, but more and more children, is that the attachment behavior, which is the young infant or young child seeking a caregiver at the times that he or she feels in danger for support, is both goal-directed, so it's meant to bring them into proximity with each other, and it is instinctive. It's not something that has to be learned. It's the way we're made as mammals. And we know from any number of studies that this attachment behavior maximizes the chances of survival. Furthermore, the attachment behaviors between young children and their parents are critical in developing what are called internal working models of relationships. Well, what are those? Those are the way the child feels about himself or herself based upon what he has come to learn over time from the way he has interacted with and been interacted with from his primary caregiver. So in a well-working system where what the child senses is that he is loved, he is valued, he is worthy, secure attachments develop. If, on the other hand, the child over time feels unloved and rejected or angry and confused, then those attachments, sadly, are often insecure. And that has significant implications both for their childhood well-being as well as their long-term adult well-being. Because as Peter Costello, who is an attachment psychotherapist, says, the internal working model is a kind of guidance system that tells us what to do and what to expect when we're with another person. They are scripts for social interaction. And as we think about internal working models, I'd also ask you to think about the parents that you see on an ongoing basis. And ask yourself, when you are seeing challenges in interaction with parents, what is their internal working model? Do they come from a secure attachment model or an insecure attachment model? And think about how that potentially impacts both their working relationship with their child and with us as staff. Beatrice Beebe is another psychologist and psychoanalyst, and she did a series of experiments that were absolutely brilliant, in which she looked at mother-infant dyads, very young infants. These babies were often as young as 4 months of age, in something called the still face experiment. And in this particular experiment, you have a mother and baby who are facing each other. And in the first 2 minutes, the mother interacts with her baby as she ordinarily would. Then she turns around, and when she turns back to her baby, she has a blank face. It's as if a curtain has been pulled over her face. It's as if she is that profoundly depressed mother you saw, for example, in that slide. And it's very interesting to see how quickly dysregulated the babies become. Babies who had been interacting socially and delighted a few minutes earlier, when the mother puts on the still face, very quickly get dysregulated. At the end of that 2 minutes, the mother then resumes her typical behavior. And what Dr. Beebe found in this video analysis she did, in which she broke the behaviors down into 0.4 second little snapshots, is that there were different ways of interacting that mothers had with their babies. There are some mothers who seem to be flexible in their approach. They seem to be well regulated, and their interactions with their babies are well regulated. And these are mothers, for example, who can go with the flow. So, for example, if the baby looks away momentarily, that's okay, because the baby will come back and they will interact again. On the other hand, on either side of that are either on the right, those mothers who had preoccupied types of interaction styles in which they tracked the baby constantly. So the baby could never get away. If the baby turned away, the mother turned away, as if to catch the baby, as if to bring the baby back, because it would just be too painful for the baby to be out of her sight for a moment. And on the other side of that are a style, or is a style of interaction of low tracking mothers. In other words, babies who were lost, like the mother that you saw on that prior slide, where the baby could be doing anything and can't get the mother's attention. So what I'd like to suggest to you is that in this mid-range balance model of attachment, there can be disruption, but because the baby's history with the mother is one of good repair, those babies feel safe, those babies will come back, and those babies will be secure. On the other hand, on either the left or the right, those were babies and mothers who tended to have insecure attachment styles. And this was actually borne out by Dr. Beebe's research, which showed that the interactions that the babies had with their mothers at 4 months of age were very similar, as were the attachments similar, secure versus insecure, at a later time with the same mothers and babies, in which there could be formal assessments of the degree of attachment. So let's talk for a few minutes about the infant attachment behavioral system and the biology of stress. Brain maturation is experience dependent. So think about where babies are at in terms of their brain maturation when they are in our newborn intensive care units. Many, if not most, of our babies are at a very early stage of brain maturation when the structural development of the brain is still very, very active. So what you come to know early on in life will influence how your brain actually develops. We know that even in the fetal environment, there are protective mechanisms to protect the baby against stress. So, for example, the placenta is the source of a large amount of cortisol, but there is an enzyme in the placenta that deactivates cortisol to an inactive form through most of the pregnancy. And it's only when the baby nears term that those enzyme levels go down so that there can be enough cortisol produced to turn on surfactant production. We know also from experiments done in the 1970s and 1980s that the way babies interact with their caregivers, typically, particularly their mothers, very early on, is manifested in their stress biology, both early in infancy and later. So this is a picture of a research model called the high or low licking and grooming rats. And in a nutshell, rat mothers, have a naturally occurring difference in their behaviors. Some rat mothers are high licking and grooming. They're all over their babies. Other rat mothers are low licking and grooming. So when we think about the kinds of interactions with babies that we thought about, for example, in Dr. Beebe's experiments, as you can imagine, the low licking and grooming mothers would be those mothers who were low tracking. The important thing to take away from this is that when studied, the rat babies of the high licking and grooming mothers had lower cortisol levels, they had lower anxiety, and they were more attentive when they potentially became mothers. On the other hand, the low licking and grooming rat pups had higher cortisol levels, higher anxiety, and lower licking or grooming. But the really most fascinating thing about it all is that you could cross-foster these babies. If you took low licking and grooming babies, but had them fostered by a high licking and grooming mother, they looked more like her rat pups. Unfortunately, the converse is true as well. There has been, that I'm aware of, one attempt to reproduce this in a human model. Barry Lester, who's a psychologist at Brown, did a cohort study of term healthy infants whose mothers did and did not breastfeed. And this is an imperfect model. It is not to say if mothers don't breastfeed that they necessarily have insecure attachments with their babies. But what was important about this model was that at 5 months of age, babies who breastfed had decreased changes in what's called the glucocorticoid receptor promoter, which essentially it will result in the receptor that will be able to scavenge cortisol from the system, and decreased cortisol reactivity, which in essence is analogous to the behavior seen in the high licking and grooming rat pups. We also know from some biology, some work done with infants and children of mothers who had depression, and this was diagnosed clinical depression, that if a child has a secure attachment in the solid gray line, then her child or her baby will have less of an inflammatory response when measured than a baby who's got an insecure attachment with his mother, another powerful indicator of the value of secure attachments. There are several different attachment styles seen in adults, and the important thing to keep in mind here is that when we have secure attachments, we have adults who are comfortable with intimacy and autonomy, who can engage in relationships and can thrive. When we have insecure attachment styles, whether they be preoccupied or very anxious attachment styles, or dismissing avoidant, which basically are removed attachment styles, health and well-being are compromised. And in the case in which we have what are called either fearful or disorganized attachment styles, often health and well-being in social emotional domains is significantly compromised. If you look at a general population, about 2/3 of children have a secure style, about 15% an avoidant or dismissive style, about 9% an ambivalent or preoccupied style, and about 15% that disorganized style. However, if you look at maltreated children, very few of them have secure attachment styles. And unfortunately, almost half of them have disorganized attachment styles, which, as I commented previously, potentially are associated with the development of psychopathology in later childhood or adulthood and poor social emotional well-being. So we ask ourselves, of course, are attachment styles stable through life? Well, the answer is it depends. If you have middle-class white children, the answer is largely yes. If you have high-risk children, on the other hand, the answer is largely not. If you look at adult women who have particular styles established, they're pretty consistent. It's unfortunately the case that as children who are in high-risk situations age, they may very well drift, even if they happen to be securely attached early on, to a more avoidant or dismissive attachment style, and that is directly related to childhood adverse experiences, or ACEs, as many of you are probably familiar with. And what about our preemies? Are they necessarily going to have less secure attachments? And the answer, fortunately, is no, they're not. Looking at a population of very low birth weight infants from 3 NICUs in the UK, who are on the smaller side, they had about the same rate of secure attachment. However, as you see on the far right in the gray, they had almost twice the chance of what we call a disorganized attachment, once again, potentially related with more serious social emotional well-being issues as they age. And for those of you who follow the literature around outcomes for particularly our youngest preemies, you know that once you get beyond cerebral palsy and cognitive impairment, the most frequent, actually even more frequent, although perhaps not as easily recognized as CP and cognitive impairment, are social emotional well-being challenges, particularly autism and anxiety. So adult attachment styles also are linked to the biology of stress and to health outcomes. And just very quickly, talking about some of the data that's available, we know, for example, that telomeres are little finger-like projections on the ends of chromosomes that are related to biological aging. If you look on the left and you look at telomere length as a function of age and anxiety, there's no relationship between anxiety alone and telomere length. If, however, you look at individuals who had anxiety and adverse childhood experiences, as you can see on the graph on the right, there are significant differences in the length of telomeres based upon those individuals who had adverse childhood experiences at less than 18 years of age. We know that this plays out in adult care for chronic disease as well. So we know that adults who have dismissive or avoidant attachments and are diabetic are less likely to follow recommendations in terms of their general diet, their exercise, their glucose testing, and their foot care, and are also less likely to be compliant with their oral hypoglycemic recommendations. And we all know about the devastating impact of untreated or suboptimally treated diabetes on health. And then finally, when we look at social relationships and mortality risk, and this is a meta-analysis that had over 300,000 participants, it's interesting to see that if you look at how social relationships predict early mortality, there is a very dramatic relationship between being very well socially connected and living longer. And the converse of that is also true. Loneliness is a horrendous risk factor for premature mortality. Indeed, loneliness is more of a risk factor than smoking and obesity put together. As we think about the importance of secure attachment in supporting young children, we have to think about what the messages we want as caregivers of among the most vulnerable children to be to our policymakers. And I would suggest that we both think globally. So we need to support and fund strategies to raise families out of poverty and to reduce ongoing adverse experiences to promote secure attachments and enhance health. But also notes to ourselves as individuals who provide care to the tiniest and youngest of babies, we need to act locally. And we need to think about things such as how can we minimize the disruptions of expectancies of preterms or otherwise high-risk births in our environments, in our parental care of the baby, in our staff care of the parents, and in our care for each other. So I hope by now that you would agree that babies, children, and adolescents who are supported and scaffolded by adult caregivers who recognize their own and their children's unconscious nervous system responses will be resilient and protected against toxic stresses. You've heard a number of presentations of individuals who are trying to do just that over the course of the last couple of weeks. And I hope that this presentation, among others, will reinvigorate you. If you are interested in learning more about the work that I do, I actually do have a book that is being published this fall, Polyvagal Theory and the Developing Child. It is available for pre-order now on Amazon. And I always thank my best teachers, my 3 children, now all young adults, and you and the larger world of providers who work diligently in the care of others. Thank you so much.
Marilyn, that was so excellent.
Oh, hi. Hi, Kathy.
Hi.
Love to see you. I'm going to put my camera over here.
Thank you so much. It has been just a privilege to learn from you. I'm sorry to jump in here, Sharon and Lauren. I just wanted to say thank you to Marilyn. And I always learn something new. I always get reinvigorated about this idea about attachment. And I know that you and I share this passion around trying to find ways to just find those practical interventions every day. So I'll ask you a question that someone asked me just the other day in a talk I gave, which is, what are the things we can do when we do have separation? So say maybe a mom's incarcerated or a mom is very sick in ICU for 2-3 weeks, and they then don't get to do skin to skin in those early days. What are some of the practical things that staff can do to help that reconnection?
Sure. I think that's a great question, and it comes up all the time. First of all, make sure somebody's doing skin to skin with that baby, hopefully. Or if skin to skin isn't appropriate, for example, somebody is holding that baby, being in physical contact with that baby. The other thing is, although there may have been a disruption with the mother, let's put the incarcerated woman aside for a second, because that's a totally different matter. Let's talk about the more frequent, the mother who's been sick, who's been in the ICU, who's had COVID. Bring them back together and start it. Yes, you've lost some time. But it's about the repair.
Yeah.
And we have many, as you do as well, mothers who have been ill, particularly in COVID, who may not have been able to come into the unit to be with their babies, but get them started and assure them that while there has been a disruption that you feel awful about, because we all feel awful about those disruptions. There's not one of us who hasn't left the unit aching because we can't have a mother or a father or whoever it was in the unit. But get them back in touch with each other physically and provide the support to her to understand that it's the repair, not the disruption. And keep repairing. Now that sounds simplistic. The other thing, if you want to talk about the incarcerated population, for healthy newborns, this is not for NICU babies, but there actually are some models that allow the baby to be with the mother. Yep, there are. And I cannot provide enough support for that.
Yeah.
Particularly when you
That's
consider
great.
that the vast majority of women who are in prison for nonviolent crimes, the vast majority of them are there for drug offenses.
Yeah.
Are we going to punish the baby and the mother?
Then you're just continuing the cycle, right? Of that. Probably some of those behaviors were driven by their own lack of attachment, and now you're penalizing and sentencing the baby to similar detachments, which will then result in maybe a cycle of repeating similar behaviors over time. So, no, I didn't know that some of those programs existed, so that's amazing. I will put that on my list of things to advocate and support for sure. So I'll let the ladies, Lauren and Sharon, take back over and see if there are any questions, but I wanted to just pop on and just say my huge thanks again for being with us and taking on this kind of unusual way of broadcasting. But I think your message is so powerful, and the science that you can share and the way that you just crystallize it, it's just the tip of the iceberg. I know I've heard you give several different talks, so I hope that people do pick up your book and learn more about how the amazing science that you've gathered for us and can help guide our practices. So Sharon and Lauren, anything else to add or new questions?
I was actually wondering myself, do you think that having these private or family NICU rooms that are private is helping with the maternal infant separation, or what do you think about that?
There's no question about it. It's unequivocal. It's unequivocal. Sadly, I work in a ward style unit. I yearn for a single room unit. There are some downside risks. Let's talk about it. The downside risk is that if you don't have the presence of somebody with the baby, then you've got a toxic disruption potentially. So ideally, I think we would have hybrid units so that in the event, I'm think about places like Wyoming and Idaho, for example, and how challenging it must be for them, for parents who might live hundreds of miles away and have other children to spend time. So ideally, I think we have a hybrid unit where if there are things that interrupt the ability of a parent to be present, either other children or incarceration or something, we have babies who could be in proximity, for example, to other caregivers, whether it be cuddlers, whether it be nurses, doctors. We can't isolate those babies. The one negative outcome that I'm aware of from the single family rooms is potentially lower language development, and it was directly related to the presence of parents. It should be the standard for all new construction, no question about it.
Yeah.
I like the idea of hybrid. So I think if you do have big families who are long distances or have illness where they can have that more of community exposure to language, even if it's not always direct language. But yeah, I think that St. Louis study definitely made us aware of private should not equal isolation, because that's just, like you said, so much more detaching. So I love that you brought that up.
Jacqueline is saying excellent presentation with nuggets for action on all of our parts, which I love. And I think that's what the conference is about, right? We get the science and we're learning about what we can do. And your talk really speaks to both sides of how science and our heart and minds are connected with the outcomes of our babies. A lot of people are just saying, thank you. Love hearing the science supporting what we do at the bedside. Much appreciated. Liz is asking, do you have any studies that nature also plays a part?
What does she mean by nature?
Liz, can you hear us? Maybe you can put in the comments.
I'm wondering if she's meaning like nature versus nurture. So like maybe genetics?
Well,
Yeah.
that's why if she's talking about genetics, yes, there are genetic predispositions. But think about those high licking and grooming and low licking and grooming rats and cross fostering. For example, you might have been born of a low licking and grooming rat, but so to speak, I hate that. that didn't go over so well. But if you are cross fostered, you will look a lot more like the high licking and grooming rat. And we've seen that played out in the brilliant work that Charlie Zena has done with the Romanian orphanages. I think some of you are probably familiar with that. So what they found, for example, and believe it or not, they actually randomized children to either go to high quality foster care or remain in the orphanage, as awful as that sounds right now, but they didn't have the data, they didn't know. And they found that the children, and obviously these children were extraordinarily vulnerable, high risk. They had been abandoned to orphanages where they were fed and clothed but got essentially no hands-on care. But if those children went into high-quality foster care, by about 17, 18 months of age, they did dramatically better than the children who remained in the orphanages. So I don't think, and I know, and somebody's going to say, but yes, those children often have been so impacted over time, and they have, but don't give up on them. There are still opportunities. They may require a very different kind of parenting than we would give to a more typical child, but that capacity is able to be retrieved.
Yeah.
Excellent.
Yeah. Liz says nature versus nurture. So I think you answered her question perfectly. And Jackie says many mothers and families have many barriers such as childcare, transportation, unstable housing to come to be with their baby. And I was wondering too, I don't know how many, I think this is changing, but still in our unit and definitely with COVID, we only allow parents to visit. But why do we get to choose that? I feel like the parent should be choosing who's visiting their baby, not me. And if they say, I want my sister who lives 5 minutes away from this facility to come and visit anytime, then who are we to stop that?
That's a really difficult one, Sharon, because at the same time, we also have a responsibility to keep other families and staff safe. So we are struggling with that in our unit now. At one point, only one parent could visit each day. It was awful. We now have both parents back in the unit, and they can be in the unit together. I agree with you. The pandemic has asked us to deal with issues that 2 years ago we would have thought unthinkable. What do you mean we'll say that only one parent can visit a day? That would never happen. And then the pandemic.
Something I've seen in our unit, as we've always allowed both parents to visit throughout the pandemic, we just opened up to allow the grandparents to visit. It's created questions where I'm getting from nurses, am I allowed to let grandmom hold the intubated baby? And our nurses have come up with this idea that only a mom or dad can hold an intubated patient. And I told them it's got to be a case-by-case basis, because we often have families that mom and dad are back to work and they only can get there maybe Friday, Saturday, Sunday, and they're sending grandmom all during the week because grandmom's retired and can spend time. And I'm like, we want that baby to have that benefit of being held. And I always say the first question you have to ask mom or dad is, are you okay with grandmom holding? Because we never want grandmom to have that first hold opportunity. We want the parent to be able to hold their baby first. I said, and once we get the okay from parents, as long as it's safe for the baby, we need to get that baby out of bed and have that nurturing from that other family member, even if it's not the mom or dad. It's interesting. The pandemic is what raised that question. We never used to get that.
Now, do you have a single family room unit, or are you a ward style unit?
We're all of it. We're full private rooms, bays, and semi-private. So we've got a little bit of everything.
Okay.
So it's only 2 people at the bedside at a time, but it's the 2 parents and up to 2 other designated, like grandparent, or if it is an aunt, uncle, whatever, caregiver. So 4 total are allowed to visit in our unit now.
Yep. Each unit is working their way through.
Yep. Somebody's asking vaccine passport for visitors. And what I feel like most units are saying, they're not asking for proof of vaccination, just doing normal health screenings is the most common thing I've heard, like illness screenings.
Yeah, we are not screening for whether people have been vaccinated or not.
Someone's commenting that they had a mother of one of their patients die from COVID, and that the grandmother was the one that was there every day holding the baby.
I would also, Lauren, just want to support what you said about case by case, because you have to be willing to consider special circumstances.
Yeah. Jan's saying, thank you, fantastic talk. In terms of stress and attachment, does it make a significant difference having multiple caregivers? Our unit does not support primary care, and I worry about inconsistent caregivers for our little ones.
Oh, that's a great question. I don't know of any data on that. But we certainly all see the difference. In our unit, we have primary team nursing. I hate to say it, I'm a great fan of the old primary nurse model. But the practicality of that, I think today is rather low. But certainly when you look at how parents react and respond, whatever you do, don't say to a parent, I've never taken care of your baby before. I mean, that is a non-starter. That is a non-starter. That's an anxiety that you need to keep to yourself. Manage your own autonomic nervous system. You can handle that differently.
I was just thinking back, it's been a long 2 weeks, but didn't we have a talk just recently about,
Michelle.
okay, thank you. I'm trying to think where were we when we had that conversation about primary nursing? Who was that?
Rochelle Sy,
That's right, Rochelle's data.
Just did is showing that the primary nursing model, whether it's primary team nursing, that those babies had better outcomes at, I think, 2 years of age.
Oh, really? Has she published that?
I think
it was part of her PhD.
Yeah,
it was part of her dissertation. So I think she's planning to publish that coming out. And so she was looking at the stress, and she happened to also look at that as a variable. So that's right.
Wonderful.
That was on our very first night.
Yeah.
I'll look forward to that coming out.
Yes. And I think it's going to make us rethink a lot of how we've shifted away from that over the last decade.
It's not just nurses. As neonatal intensive care divisions get larger, my division is huge now. We used to be a cozy little group of 6 who did all the coverage. There are now, I think, about somewhere between 14 and 17 people who come through and attend in our unit.
Yeah.
Very different.
Yeah, no, that's a really good point too, because that is so stressful for the parents, for the providers themselves, right? And it's even I know when I used to do night call, you're like, you do have to check yourself and say, oh yeah, I don't need to say I don't know your baby. I just need to go and learn about your baby before I come talk to you.
I think it stresses out the nurses too, because we hear, oh, I just came on service today, so I'm going to take the next few days to figure your baby out, and then we'll continue the plan. And the nurses feel like we had a great plan and a great trajectory, and then we stop so the new team can learn, and we feel like it's a 3-day pause in care instead of continued progress. And so the nurses get stressed out with it.
I think one of the things our group has done a pretty good job on, not perfect, but pretty good, particularly for those babies who are more complex, would be proactively addressing that, such as if I'm on and I know that I'm thinking about a significant plan for baby Jones, I will often invite the person who's coming on after to join that discussion. And we talk together, and we probably come up with a better plan because I have their input. And I just think that's really important. So the other thing, and this is just something I do, you can reassure parents that even though you might not be present, that you will be available. And so I will often, if they're parents who are particularly challenged because either their baby's really sick or whatever's going on in their own lives, and if I go off for a weekend, I'll just say to them, I'm off for the weekend, I'll be back Monday. But I assure you, if Dr. Jones needs to reach me, she knows exactly how to do it. And yes, I have gotten calls from time to time on the weekend saying, this has come up. This is what I'm thinking about. What do you think? If you guys can't work like that as a collegial group, there's something wrong.
That's a really great model. And that's a really nice example to just show that it can be done. Like that's what I love about this conference, right? So when you see it's been done somewhere else, then you say, oh, we can hold that as possible now, not impossible. So I love that, Marilyn, that your team has been able to find a way to cross-cover each other, either the coming on and coming off or across a weekend, because those really are those stressful times when things come up. That's amazing. Sharon or Lauren, any other questions that have popped in? I feel like we've got through them all, but.
That's good.
I think we tackled them all. Lots of positive feedback. Just thank you for sharing your expertise.
My pleasure. My pleasure.
Thank you again, Marilyn, for being with us. Well, that wraps up week 2 of our Silent Night in the NICU series. So just again, big thank yous to Dr. Sanders and to Lauren and Sharon for being the moderators of that session. If you are enjoying this series, Silent Night in the NICU, go ahead and do me a favor. Hit that like and subscribe button on our YouTube channel. It helps us out a lot. And if you want to get the resources, go ahead and click the link in the show notes below. You'll be taken to a page where you enter your email address and you'll get instant access to the replays, to resources, and other things that we don't share here on our YouTube channel. Without your support, we couldn't bring you all this free content. So thank you very much. I really hope you're having a great holiday season. I'll see you next week for our week 3, where we're going to talk about sleep in the NICU again. And I think for now, I'll just say thanks again for being here, and I'll see you next week. Okay, bye.